Let us start the session today. The topic is acute renal failure, and the speaker we have today here is Dr. Nikhilesh Jain, who is the Director and Operational Head Depth of Critical Care Services Care at CHL Hospital, Indore. Thank you, sir, for being with us. You can take over the class.
So, over the course of next 30 to 40 minutes, I hope to cover a major part of this important topic, that is acute kidney injury. And let's see how it works out. Uh, so, why is acute kidney injury important? It's a syndrome which is characterized by a rapid deterioration of kidney function. By rapid, I mean hours to days. And there will be certain clinical consequences of AKI, which will include the accumulation of waste products, electrolytes, and fluid, but also less obvious effects, such as lowering of immunity and dysfunction of non-renal organs, what we all commonly call as organ crosstalk. There's a very good amount of increasing evidence that acute kidney injury is actually associated with serious short and long-term complications, in particular, increased morbidity and mortality. So when we talk in terms of defining or labeling a patient as acute kidney injury, what are your diagnostic and definition based cutoffs that you want to use? Am I audible? Am I audible?
Yes, sir, you are audible.
Okay. So the common ones that we use are rifle, Akeen, and there would be one more score, KD-GO, that would come later on in the course of the presentation. So rifle, in that we actually define RIF, that is serum creatinine increased to 1.5 fold, or a GFR decrease of more than 25% from baseline. This is the serum creatinine criteria. I is the injury part, that is serum creatinine increases to twofold or GFR decrease of more than 50% from baseline. Then F is failure, wherein you get a serum creatinine increase to threefold, a GFR decrease of more than 75% from baseline, or a serum creatinine of more than or equal to 354 micromole per liter, that is more than 4 milligram per deciliter, with an acute increase of at least 0.5 milligram per deciliter, at least 44 micromole per liter. On the other hand, you have the urine output criteria, which is less than 0.5 mils per kg per hour for 6 hours. Again, which is less than 0.5 mils per kg per hour for 12 hours for eye or injury part. And for failure, it is less than 0.3 ml per kg per hour for 24 hours, or a proper inuria for 12 hours. When it comes to Akin score, you divide it into various stages, stage 1, 2, 3. So stage 1 is again a serum creatinine increase of more than or equal to 0.3 milligram per deciliter, or an increase to 1.5 to 2-fold from baseline. Stage 2, you get a serum creatinine increase to more than 2-fold to 3-fold from baseline. Stage 3, you get a serum creatinine increase of more than 3-fold from baseline, or a absolute serum creatinine value of more than or equal to 4 milligram per deciliter, with an acute increase of at least 44 micromole per liter, that is 0.5 milligram per deciliter. And when we use that for urine output criteria, so urine output criteria remains the same whether you are using the rifle score or the Akin score. So points to remember whenever you talk about acute kidney injury are: oliguria will actually precede your rise in serum creatinine. Anuria can be taken at 50 mils per day. Once you've detected it in a patient, you should look for any reversible causes. In general, non-oliguric AKI has a better prognosis. There's only one publication which actually does not favor this point. And recognition of non-oliguric patients is very important, as they may require, the statement that I'm using is may, so they may require early dialysis. And longer the oliguria, more is the mortality and more is the severity of the injury. Now, whatever scoring systems we use, they actually help in prediction of mortality and sometimes the further course of the acute kidney injury. So if you have a patient who's got suspected oliguria or anuria, you need to do an hourly monitoring of urine output. You need to assess the catheter position and patency, examine if there's any palpable bladder, look for any flushing, if there is any flushing of catheter that may be required. Establish if there are any mechanical reasons because of which you are getting oliguria and anuria in this particular patient, and try to look for any other causes which can be causative for acute kidney injury. So how do I diagnose it? So this is the KDIGO definition and classification. This is one of the most widely accepted. So in this, the diagnostic criteria would be acute kidney injury would be defined as any of the following, increase in serum creatinine by more than or equal to 0.3 milligram per deciliter within 48 hours, or increase in serum creatinine to more than or equal to 1.5 times of baseline, which is known or presumed to have occurred within the prior 7 days, or a urine volume, absolute urine volume of less than 0.5 mils per kg per hour for 6 hours. Then you have a staging system. If you're talking about AKI stage, then you can use again serum creatinine criteria and urine output criteria. So acute kidney injury stage 1, again increase of serum creatinine by more than or equal to 0.3 milligram per deciliter, or increase to 1.5 to 1.9 times from the baseline. If you've got stage 2, then you get an absolute increase in serum creatinine to 2 to 2.9 times from baseline. If it is stage 3, then you get an increase of serum creatinine of more than or equal to 3 times from baseline, or an absolute value of serum creatinine more than or equal to 4 milligram per deciliter, or this patient requiring a renal replacement therapy, or in patients who are less than 18 years of age, the decrease in estimated GFR is to the tune of less than 35 mils per minute per square meter of body surface area. When it comes to urine output criteria, you've got a urine output criteria of less than 0.5 mils per kg per hour for 6 to 12 hours. Then it is less than, for stage 2, it is less than 0.5 mils per kg per hour for more than or equal to 12 hours. For stage 3, you have less than 0.3 mils per kg per hour for more than or equal to 24 hours, or the patient is frankly anuric for more than or equal to 12 hours. However, you have problems with serum creatinine. Now, I would be touching this problem with serum creatinine again and again just to drive the point home. So, serum creatinine is synthesized from glycine and arginine in liver, kidneys, and pancreas, and it serves as a reserve for phosphate in muscle. Then it is determined by amount of creatine generated in liver, pancreas, and kidneys, ingested creatine, and muscle function. It is freely filtered by the glomeruli, and if it is healthy, if the person is healthy, it is produced and excreted at a constant rate. So what you are getting is a secretion of creatinine in the body per se, and half-life of the same compound increases from 4 hours to 36 hours in those patients who have renal impairment along with decreased GFR. If you've got patients who have got severe sepsis, who have got liver disease and muscle wasting, then this creatinine is not reflective of fall in glomerular filtration rate, or it does not go hand in hand with glomerular filtration rate. So when we talk in terms of potential pitfalls of AKI diagnosis, which are based on creatinine and urine criteria, so you can get clinical scenarios in which administration of drugs has been done, which interfere with the tubular secretion of creatinine. So you may get a higher value, such as cimetidine and trimethoprim, and then you can get decreased production of creatinine in patients who have liver disease, severe sepsis, or muscle wasting. Then certain times there can be ingestion of substances which lead to increased generation of creatinine independent of renal function. That is an oral ingestion of creatine or cooked meat. Then obesity, you can overdiagnose acute kidney injury if you're using actual weight when when you're actually applying the urine output criteria. Then conditions which are conventionally associated with physiologically increased GFR, such as pregnancy, wherein you may get a delayed diagnosis of acute kidney injury. Then certain times you may have certain chemical substances which will interfere with the labs, with the actual analytical measurement of creatinine. It is done by Jaffe method. So there can be certain common compounds such as 5-fluorocytosine, increased bilirubin levels, wherein it can lead to misdiagnosis. Then those patients who have undergone fluid resuscitation and are currently in overload, So in these patients, there may be a dilution of serum creatinine concentration and there may be a delayed diagnosis. There may be those patients who have got a progressive chronic kidney disease with a gradually increasing rise in serum creatinine. They may be misdiagnosed as acute kidney injury. Extrinsic creatinine administration as a buffer in medications, as it happens in patients who receive IV dexamethasone or azacetrol, wherein it is referred to as a pseudo-acute kidney injury, or there may be oliguria due to acute temporary release of ADH, that is post-operatively, nausea, pain, which is enhanced by maximal sodium reabsorption in the setting of volume or salt depletion, which leads to a misdiagnosis of acute kidney injury. So this is how the generation and clearance of creatinine happens. It's a schematic. It is just a schematic diagram about how it cycles through the liver, kidney, muscle, and the systemic circulation.